So Spring Booster campaign, we started back in April, offering the vaccination to a narrower cohort of patients. So anyone over the age of 75 and also groups who are immunosuppressed. We started with housebounds and older age care homes back in April, and the campaign runs through to the end of this month, June. So there is still time to get your vaccines if anyone needs that booster dose and is eligible. We're also offering it, the group that hasn't come forward as much is the immunosuppressed group. So these are people with severe immunosuppression, either through a condition or through medication. So things like high dose of steroids, immunosuppressant medication for inflammatory conditions like rheumatoid arthritis or inflammatory bowel disease, and people having chemotherapy or radiotherapy for cancer would be eligible. So it's a smaller group for the Spring Booster campaign, if you like, as well as that older age population over 75. Come autumn, we go again with a wider cohort. So usually it's over. We haven't had the final groups from our joint committee for vaccination and immunization, but it usually aligns with those having the flu vaccine. So those over 65 and those with certain conditions. So invites will go out in due course for the autumn campaign, which usually kicks off from September onwards. But right now we are in the NHS. It is a challenging time as always with the NHS, but generally we're always about, I'm a GP, so I'm about that prevention. I'm about the wider health, holistic health issues. So that's why I really love the topic in terms of generally getting ready, summer health, things that we should be looking out for. And you've submitted a really great wide range of questions that we can get on and tackle. So thank you again for having me, and looking forward to the conversation this morning into afternoon.
Excellent.
Thank you. Thank you so much for that succinct introduction. And we now go right into the questions. Yes.
Shall I put some in the chat so people will be reminded of some of the questions that have been submitted, or is everybody okay? I see some people are putting stuff in the chat already, but we're going to take the ones that have already been submitted first of all. Would you do you want me to put them in the chat, or
yes, or perhaps you
share them, or whatever is easiest for you, Dr. Ilozue. Have you got them?
I don't mind. I've got it on I've got a second screen, so I've actually got them on this screen here.
Good.
So
okay,
yeah,
like that then.
Maybe easy enough to just go through them like that then.
Okay, let's fire off. Right, the first question is your starter for 10. What are the side effects of the COVID vaccine?
So yeah, really common question and a concern. All medication, all vaccines have potential benefits, of course, because we wouldn't give them if there wasn't a benefit, but everything has side effects and risk, even your normal paracetamol tablets. So the main side effects of the COVID vaccination, we've been tracking it since we gave that first dose all the way back, it feels, in December 2020. Was 2020? Yes, it was December 2020. Just trying to remember the dates now. But yeah, so it was done, the vaccination came out a lot faster than a lot of us anticipated, even in the medical community. But it's because there was a reason, there was a pandemic and there was a real incentive to get a solution. So we had lots of different people working together, government, researchers, and there was also a lot of work that had been done. We've been vaccinated against infectious diseases for decades and decades and decades. So the vaccine came out, there were trials done, so the side effects were looked at, and then obviously we've tracked it since then, and the tracking continues. So the main side effects from this vaccine are sore arm at the point of entry, so muscle aches. Some people do feel, because the point of the vaccine is that it's stimulating your own immune system. So some people are a bit run down for a few days afterwards. It cannot give you COVID, or the flu vaccine can't give you flu, but some people feel that they feel very run down and feel unwell but it's usually a few days. They may have a fever, nothing that paracetamol or some other antipyretics can't deal with. Some people, so it goes into the common side effects, which are the sore arm, feeling run down for a few days, a bit achy. to the more serious and rarer side effects. So all medication have potential severe side effects, and some of the more severe side effects of the vaccination in young people in particular, there was a link to inflammation of the heart with Pfizer, you know, and then with the AstraZeneca, there was a link to clots in the younger age group. And that's why the change was made not to offer it to under 40-year-olds. And actually, AstraZeneca is not being used anymore because we're now focusing on using the mRNA ones, which is Moderna and Pfizer. Some linked it to, you know, there are lots of different very, very rare complications, like a major severe allergic reaction to any of the ingredients in the vaccine. But that also happens quite rarely. And if someone has a known allergy, then that may be more, they're known, and then we maybe vaccinated them in a hospital setting rather than in a community hub. So those were the main things in terms of the side effects. We have a yellow card system, which we are to report any side effects from any medication or any vaccines or drugs that we give. So the MHRA, which is our regulatory drugs agency, are collecting this all the time and reporting, and you can go and report. And people argue that it's underreported, but it's very important that if people feel that things are linked to vaccination, that they're filling this in. So public can report, GPs, doctors can report. So it's really important we are consistently monitoring and looking at all the wide range. But generally speaking, with any medication, like I said, we have to weigh up the benefits with the risks. And overwhelmingly, the benefits of being protected with the vaccination outweigh any potential risks of side effects or complications.
Thank you very much. And it's one of those really difficult things that everyone thinks about what can go wrong and forgetting the hugely beneficial effects of the vaccine. Now, we've got some more questions on the vaccine. I'm going to lump some of them together. How important is it to get the COVID vaccine? I've had so many COVID vaccines and boosters. Do I really need another one? I think a lot of people are asking
Absolutely.
that question. Although I have had all the jabs, I still got COVID. Do I really need to have another one? And we'll leave it there. And then there's another couple of questions.
So it is really, really, at the moment, we are in a season, we talk about it in the delivery groups, of vaccine fatigue. You know, people are being invited for vaccines left, right, and center. And it's really been front of awareness, obviously with the pandemic, with COVID, but we've had flu vaccine. I'm down in London, so we've had an issue with, you know, measles, you know, outbreaks in parts of London. So we've been really pushing the MMR vaccine. We've now extended the age. I think there's a question about shingles vaccine. So it feels like vaccination is coming from everywhere. But we have to go back to the original reason for vaccination. And vaccination is about prevention of infectious diseases. In the case of COVID, we thought initially, I think a lot of the messaging was like it would stop you getting COVID. But actually what we realize is that it does boost your own immune system to create antibodies that protects you against COVID. And if you were to go on and get COVID, we know that that infection was much, much milder. So then the aim became, let's prevent hospital admissions and all those awful scenes we saw of intensive care units being full and hospital beds running out and oxygen running out. We don't want people to get to a point where they're ill enough to go to hospital. COVID is now what we call endemic. So it's there. It will always be around, similar to flu, similar to the common cold, and lots of other viruses and things we contend with. So it won't ever go away, but it's about protecting the most vulnerable population, in particular, people who are more risk of having severe illness. So during the pandemic, we were offering the vaccination to everyone. You know, we went by age. We started with oldest and went down in the age cohorts. Now we're only offering it to the older age group. So over 65 for the autumn season and over 75 for the spring campaign, as well as those who are immunosuppressed. And then in the autumn season, I anticipate those of us who are carers or healthcare workers as well will also be offered it, but we weren't offered it for this spring campaign. So we have the JCVI, who the Joint Committee for Vaccination and Immunization, looks at the data, looks at the COVID virus that's circulating, because we know that there are variants, and then they make a decision which cohorts are eligible and who should be offered a booster. So it's not offered to everyone. So it's always done with evidence base. So they're offering, we know that over time, the antibody protection wanes, it reduces. So the idea is to then top that up with the spring booster campaign or the autumn campaign. So I get that you've had lots, and some people are on their sixth at the moment, even more. But like similar to the flu vaccine, how many flu vaccines have you had? If you're getting it every year, you're not counting them. Obviously, COVID's new and people are a little bit more aware. And right now, we're giving it twice a year if you're over 75 or if you're severely immunosuppressed. That may move to a year, but again, we're guided by the evidence, and they're tracking it. They're tracking the rates of COVID, the variants, numbers admitted to hospital, all of that, and making a decision based, because we want to protect the population and we don't want to get into a situation that we were in before, where COVID is running out of control and people are becoming very unwell. So there's no easy answer, and I can't say how many you would have, but I would say I encourage my patients to stop counting in a way, because I ask them, how many flu vaccines have you had? And they can't remember. It's probably, over 10, over 20 if they get it each year. So I think we have to see it as an endemic infection that will always be there. It is a lot more controlled than it was, say, 4 years ago, which is a great thing, of course. And vaccination is about controlling the rates and the severity of illness, and we want to make sure we continue doing that. So I would say if you've been offered a vaccine and you're eligible, the evidence has judged that you're more at risk, so you do need one, or it's important you get one to protect others, say. So I would advise you to go ahead and get that done.
Thank you.
Convoluted way of saying yes, stop counting.
I'm looking forward to when they can combine the flu and the COVID vaccine, so I just need one
Yes.
jab.
I saw an article about that. So that work is going on in the background. So I anticipate that will be the case in the coming years. We're not quite there yet, but watch that space.
Okay, another couple of questions specifically. I have autoimmune encephalitis. Do I have to take the vaccine? And as an asthmatic, which I was diagnosed during COVID, I'm very skeptical about the vaccine. Are there any other options that can be taken rather than what the government want people to adhere to?
So the government listened to the medical bodies on this. This is a public health measure, vaccination. So the same way we vaccinate children against infectious diseases, the COVID vaccine is very much based on the evidence and the importance. So the government takes on board what these bodies say. So in terms of keeping well, it's really important you do the whole thing. The vaccine is one tool in a plethora of toolkits about keeping well and making sure your immune system is what it is. So as an asthmatic, it's important that you're having your annual asthma reviews. It's important you're reviewing your inhaler technique and the medication you're using for that. If you're needing high dose steroids as part of that treatment, it may be that you're suppressing your immune system and you may be more at risk, and you may be definitely one of the groups we really want to come forward to protect. Because remember what COVID is, respiratory infection, as is flu. So asthma obviously affects the respiratory system, the lungs. So we want to protect you from getting more complications from that. So just having asthma and being controlled with inhalers isn't necessarily one of the groups that will invite you forward for the COVID jab. You are eligible for the flu jab each year, and we look at those cohorts carefully each year. So just having asthma in itself is at the moment, as based on last year, not one of the groups that would have been offered COVID. You would have been offered the flu. So again, you will be invited by your practice depending on the cohort you're in. Other options, I would say, are making sure you're keeping well. Your immune system. Are you taking your vitamin C, vitamin D? Are you eating the rainbow?
Are you frozen?
Are you getting enough?
Dr. Ilozue, you're freezing. Hello?
We, we lost you there for a moment, Dr. Ilozue.
Looks like
I think maybe
Julia
we're
lost
freezing
us.
on her now.
Let's just wait for a moment.
Yes. We got her.
Am I back? Sorry about that.
There we go.
Where did I stop? I just realized everyone had frozen. Apologies.
That's okay. It happens to the best of us.
It's the work. See, NHS, work Wi-Fi. Where did I get to? What was I saying?
I think we were at the point when you were saying about the updating them and moving on. I think the last thing we were saying about having the joint vaccine, maybe.
Was it asthma?
Moved on to the next. You were just coming on to the next piece
about the asthmatic. So you didn't hear anything I said
about
No.
Yes, I didn't hear anything about the asthmatic.
Okay, gosh, it was a while ago. So sorry. Please,
Okay.
yeah, I don't know how we're going to do that if that happens. Fingers crossed it doesn't happen again. Apologies again. So as an asthmatic that's skeptical about taking the vaccine and looking at other options. So
Yes.
I'd say the government, that was my query, the government only then has to sign off what the public health and the medical bodies are saying about the vaccination. And that is an offer. But there's a toolkit of things you can do to keep healthy. So being asthmatic, it affects your lungs. We know COVID and flu affects your lungs. So you may not just be an asthmatic, and if you're controlled on inhalers, you may not be in the group offered a COVID vaccine in the winter season, but you would be offered the flu vaccine every year. So I'd encourage you to definitely get that. But if you want high dose steroids, which suppresses your immune system, you may be offered COVID. And I would recommend you get that. But the other ways to keep healthy, make sure you're having your asthma review, make sure you're reviewing your inhalers and you're using them and they're working for you. And make sure that you are building your lung capacity with exercise, eating the rainbow, healthy eating goes a long way. Keeping still is the new smoking, make sure you're moving each day. We recommend, 150 minutes of even a brisk walk, around the block each day goes a long way into helping reduce health matters and complications. So all these things are in a toolkit, but vaccination is one of the most powerful interventions we have to prevent complications from infectious disease. So I'd say don't do one, do it all in parallel and holistically keep as well as you can.
Thank you. Funnily enough, there are some questions about this later on, but I think the importance of other things like a healthy, balanced diet and taking exercise and meeting people are really, really important.
Yeah.
Now, I've got a question that I've got a particular interest in. Does anyone really know the impact of long COVID and what are the symptoms?
So long COVID, kind of similar to things like chronic fatigue syndrome or maybe something called ME. So we don't know fully the mechanisms, but it's people becoming really unwell with symptoms of fatigue and not able to do their normal day-to-day activities after a viral illness. So it can strike at random, and long COVID has multi-factors associated with it. It causes multiple symptoms and it has caused a major impact in many people's lives, with them not being able to return to work and function as they did before they had COVID. So it's still poorly understood. There's lots of research going into it. It can affect every part. So fatigue, brain fog, joint aches, susceptibility to other infections, all different things. So there are different mechanisms in terms of trying to address it with multidisciplinary teams. So there should be hubs in each area that people can be referred to that can then coordinate that care and identify what symptoms are affecting you as an individual and try to address it. But it's poorly understood, lots of research still going on. We want to prevent severe COVID. because we think there is some evidence that being vaccinated may reduce the risk of things like long COVID or the impact of long COVID. So those with long COVID, I know actually a personal friend of mine has gone out and got her vaccine because she's really keen to prevent more repercussions from what she's been faced with in her long COVID journey. So really important to protect yourself from further insults and infection as well, I would say. But tough area, massively impactful area, and we can't, with all the talk of side effects of vaccines, we can't take away the potential impact of COVID itself and the complications from that, one of which is long COVID, and significant numbers are still affected, unfortunately.
Thank you. And as you say, it's a very poorly understood area, and there's well, at least there's a lot more research going into it than there was before. And a very difficult area. Chronic fatigue syndrome has had its, people have taken sides on the causes of it, and that really hasn't helped the research. So I'm glad at least that this is a spur to getting more research into what can be a very debilitating condition. Now, we're going to come back to some questions about other vaccines, but I thought we'd just steer off for a moment into more general health issues, some of which you've already touched on. So leave aside the healthy diet and the exercise at the moment. There's a couple of questions about blood pressure and stroke and drinking water that we might just touch on. Do we need to take high blood pressure medication for life, or will the medication ever stabilize or regulate my blood pressure? Can I treat high blood pressure with healthy food instead of taking more tablets? And I put those two together and I'll declare an interest. I've got high blood pressure, and so I'm very interested in the answer.
So it would be a really good, no, it's a really great question actually, and it's a common question. So high blood pressure, what is it? It's the heart working really hard, pumping the blood through our pipes, you know, our arteries, our vein, and then it comes back through the veins. So it's really important to make sure the heart isn't working too hard. We know the arteries, just with each decade, they're spurring and they may harden with each decade. So the heart is working harder to pump the blood through. So blood pressure can be linked to genetic factors, can be linked to aging factors, can be linked to lifestyle factors. So I would say it's something that can potentially be controlled with really taking a really good look at lifestyle. So reducing salt in diet can be a big way, eating that rainbow, keeping well hydrated, and getting moving. You know, those are the key things. Stopping smoking, making sure your weight is under control. Those will always be things that you should be doing. But even with those measures, because of that hardening effect and also non-modifiable risk factors like your genes, if you had parents with blood pressure, you may be more susceptible to it. Those are things you can't change. So it may be that you do need medication to keep it under control. But with everything, I always say monitor. So, you know, if you're taking a tablet, is it working? We're supposed to look at outcomes. Are those numbers coming down? And depending on the condition you have, depending on your age, we may want it to be 140 over 80 is a rough guide, but we may want it a little bit higher if you're a bit older and at risk of falls. We may want it even lower if you have kidney disease or diabetes or heart disease. We may want it right down to 130 over 80. So it depends on, you should know what your goal is, and you should have a way of monitoring it. So if you have high blood pressure, you should have a machine at home. It's a lot more accessible now, so you can keep an eye on it at home, just as good as the machines that we have here. I've got one here on my desk, you know, or you may have a pod in your GP waiting room. A lot of community pharmacists are also offering blood pressure checks. But I would say it's well within your control. Have a machine at home, a lot more accessible. So keep an eye on what your blood pressure is doing. So if you're making certain changes, are you meeting that target in terms of your numbers? So always know your numbers. Some people can control it with healthy diet and approach, but remember those non-modifiable risk factors I mentioned that you can't change, and it may mean that you need medication as well to control it. Some people need 1, 2, 3, 4. So there's always a role for lifestyle measures in maybe reducing the numbers of tablets. But I always say monitor the outcome. Blood pressure is a silent thing. It doesn't make you feel unwell necessarily. So that's why it's important to check it on a regular basis if you have high blood pressure, and look at the outcome of any interventions or changes you're making and address it accordingly. But I always have people say, oh, they're going to go on a healthy food diet, which is wonderful. Think about how sustainable it is for your lifestyle. And like I said, always monitor those numbers and outcomes, and then you can make a decision that's personalized to you.
Thank you. So it's not just one thing, it's a number of different interventions, some of which is pills from the doctor, but lots of which is about diet and exercise and so forth. And it's important that you do all of it. You can't necessarily pick and mix.
Yes.
Can I, well, sorry, yes. Can I treat high blood pressure with healthy food? Well, there was another one. There was another one about stroke. What are the causes and how can I avoid getting a stroke? Now, and what kind of food would you recommend for a stroke survivor? I'm putting these in now because high blood pressure is a major risk factor for stroke.
It's a major risk factor for stroke, alongside, being overweight, smoking, having previous heart disease, diabetes is another risk factor, but blood pressure is a major risk factor. And that's what I mean. It's a silent disease until it's not, so people are walking around with very high blood pressure for many years. And the first time that they may be diagnosed, which is a failure, as far as I'm concerned, is when they have that big stroke. So we want to prevent that. And it's important to try to control it. And that's what I mean about really knowing your numbers and monitoring. Because there's no point, some people, a friend of mine, actually, a story, and she wouldn't mind me telling, she's a doctor herself. Her father had a big stroke. So when she went to the house, guess what she found in all the cupboards? All his blood pressure medication that he hadn't taken. So it's really important to have an honest conversation about compliance. Medication, like I talked about side effects earlier, everything has side effects. So, but it's a balancing of the risk and benefit. So if you're not taking your medication, your diagnosed blood pressure, you've been prescribed medication, but you're not taking it because of side effects. It's so crucial you go back and have that conversation about how the medication's affecting you. There's other ones we can try. And really be honest, because there's no point putting it in a drawer. And apparently he said to her, my friend's father said to her, oh, I take it when I feel unwell. So blood pressure medication doesn't work that way. You can't just take it one day and then think I'm fine today, I don't need it today. And then you remember to take it next week, And it ended up, unfortunately, with him having quite a big stroke. So we want to prevent it. But there's no point us dishing out that prescription each month, thinking you're taking it and you're not. Let's have more, I think we have to have more honest conversation about compliance, side effects, and adjusting medication accordingly. So it is important to think about compliance with medications, so prevention, so blood pressure. Other things, stopping smoking, movement is really important. Building that reserve in muscle strength and also getting the blood pumping around more effectively. Eating the rainbow. Social contact is always really important. There's something about stress and inflammation, and it's an area that isn't quite understood, but we're learning more about it. So loneliness or stressful life events or general inflammation from infection, as well as other causes, can potentially increase the risk of the furring of those arteries and increasing your risk of heart disease and stroke. So we do need to look into that as well. So that's why Age UK and what it does about connection is so crucial in my eyes. So the causes of stroke, two main causes. You can get a clot in your brain or it can be a bleed. Most of them are caused by that clot, and it's the blockage of a blood supply to one area of the brain. So by adjusting those risk factors, you can really reduce your risk. Blood pressure, smoking, cholesterol level, if you're diabetic, making sure that's well controlled, movement, and I'm sure I've missed out another one, but those are the main lifestyle interventions to make sure you're addressing. But compliance with medication is key. And if you have concerns about side effects, have that open, honest conversation with your doctor or with your pharmacist. Remember, we have a wider group of professionals now that can help you with those matters.
Now, I'm just going to jump to the chat because someone's posted, what if a patient can't afford the high blood pressure monitor? Can the NHS provide free monitor to those people? And Sharon has replied, you can get your blood pressure checked at your pharmacy, and there's a link to finding your pharmacy. Now, I bought a blood pressure monitor some years ago, and I've got no idea what's happened to the price of them, but you can get fairly reliable ones, not too expensively, I think.
No,
Where's
not so
a
expensive at all.
where's a good place to look for a reliable blood pressure monitor?
Not to, promote any major engines, but, any of the main places that you get your books and shopping, or, big supermarkets will always have them, on the shelf. I've seen them there. Amazon is the one I didn't want to necessarily say, but putting it in there. But you should be able to get a decent machine for less than 20 quid. A lot of GP practices, I know we have a big box of BP monitors that we loan out when we're it's more about trying to diagnose it. So we like to do something called ambulatory blood pressure monitor, where we loan you your blood pressure and you take it every morning and evening for a week, and then we can average those results. So we can do that. But if it comes to monitoring your own disease over time, I would suggest thinking about, purchasing one for yourself so you know that it's in the house. But a lot of GP practices will have a pod in their waiting room. So if your GP is close by, you can go and use the pods in the waiting room. And like Sharon put in the chat, a lot of community pharmacists are now offering blood pressure checks as well.
Right. Now, we've talked about diet and weight and exercise.
Yes.
Oh dear, I cannot lose weight no matter what I do. Are there any recommendations that you can give me? I've heard that, well, I used to hear that in the consulting room, and I certainly struggle sometimes to shed some weight myself.
Yes, most definitely. I'm not liking this post-40 life. I'm in my mid-40s now, and the things that I could get away with 10, 20 years ago, I can't. And I can only see that being more of a challenge as the decades progress. So I can definitely identify with that. And there's been lots and lots of, news about, magic injections that will just, sort out weight problems. But it's not a panacea. There are no panaceas. Even that injection, you have to make sure there's a lifestyle associated with it. So lots of people are trying to get on to, get that as a magic bullet. There are no magic bullets. Everything needs you to approach things with that holistic, looking at lifestyle, looking at small changes you can make that make sense for you and your lifestyle, and that you can be consistent with, because consistency is key. So there's no point going on these major fad diets. They're not sustainable. And again, the body knows as soon as you stop it, it will demand what it has been deprived of, and you put it all back on as soon as you stop a fad diet. So we know they don't work. So it is important to build in things that are sustainable for you over time. But if you're really struggling, the NHS has weight management referrals. So it's a national program. Your GP, if you're above BMI of 30, or if you have risk factors like diabetes, hypertension, of a certain ethnic group above 27.5, I believe, you can be referred for a weight management service. Some are online, done nationally. There are local tier 2, we call them, weight management services, which usually involves a gym, exercise classes, advice about nutrition, and then follow through, because that peer support in the group can help, or to have that support or advice, because sometimes it can be a real minefield of where do I start? And then you need a plan that's personalized to you, and that's also it's also achievable with your individual goals and your lifestyle. So I think try to get a weight management referral. Be kind to yourself. Apologies. It's all go here. It's if you hear the fire alarm test, it's just a test. Be kind to yourself. Achievable small goals. Consistency is key, but try to get help in terms of that weight management referral, because every practice should be offering that in your local area. So those are my advice for that. But it's not easy. So be kind to yourself, but start small and build up slowly up.
Yes.
I would say.
Thank you. I decided I wanted to lose some weight a few years ago because my blood pressure was going up.
For this today.
And
Am I back? No.
hello?
Your picture is still frozen, but we can hear you.
Oh dear.
Let's see.
Well, I'll carry on if you can hear me.
Yes.
I decided to concentrate on not on going on a diet, but on a lifestyle change, so I could change what I was eating, but then carry on with it. And so I thought of it about as a lifestyle change. And I did manage to lose quite a lot of weight. This was just before the pandemic. And I managed to keep most of it off despite a lot of comfort eating while we were locked down. So I think of it as a lifestyle and as something that you can continue with. And for goodness sake, eat food that you like. And I got used to cutting down on meat and stuff and concentrate on much more on fruit and vegetables, lots of fruit and vegetables. And I really enjoy what I eat now, and I enjoy preparing it. But as Dr. Ilozue says, be good to yourself. I think that's really, really important. Are we okay to continue, Sharon?
You're back?
Am I back? I might try and just join on my laptop. I don't know what's happening with the computers at work. So apologies again for it, but I may try and patch it on my phone, on my laptop, and see if that is ready. But I'm here for now, so I'll try and do that. So just in case I may have to switch screens, but let's continue for now. But yes, yeah. Okay. Sometimes technology lets us down, unfortunately.
Yes. Sharon, are we going to take a quick break at some stage, a comfort break?
Yeah, if we want to, what time is it now? We'll say at 1:45. We could take a 5-minute break at 12. I would suggest. What do you think? Would that be easiest?
Yes. Okay. Yep, that's super. So we'll carry on. There's a few more questions. And I'm going to switch back to vaccines now, because there's some questions about the shingles vaccine. Can you give me more info about shingles and the shingles vaccination? Is it a live virus? And there's another one.
And I think all that eligibility with shingles gets a bit confusing because they're trying to change the age brackets, right?
That's right. And they've changed the vaccine, and I must say, I haven't kept up with it, and I'm sure I'm going to be eligible soon. There's also the pneumonia vaccine that I got offered, and at the same time as a COVID, and I thought, no, I'll have one at a time. But so can you just talk us through the pneumonia and the shingles?
So shingles vaccine, yes, they have changed it recently. It was a live vaccine and it was offered to 70 to 79-year-olds only. So it was only that cohort would have been offered, and it was a 1-dose live vaccine. So again, if you were immunosuppressed or having treatment for something like cancer, you may not have been offered it because it was a live vaccine. So we were careful about not giving it at the same time as other vaccines. It's now been changed to a 2-dose inactive non-live vaccine. And we're going to start offering it. It's a very complicated scheme. So my practice nurse is more au fait. But we are offering it from 65 on. But actually, if you're immunosuppressed and over 50, you'll be offered it. But there is an age target, it's like it's been done in a staggered way, so you're only eligible at certain times. So your practice nurse is the one that will know whether you're eligible, and then you should be invited. But this new vaccine, Shivaras, is 2 doses, 6 months apart approximately. So that's going to be offered to a wider range of people and from a younger age cohort than we did do, but it's been staggered. So you will be invited in due course. But if you have any questions or you feel that you are eligible, please, your practice nurse are the jewels in the system that understand this much better than us doctors do usually.
Thank you. And when is this rollout starting?
It started, so it's from September.
Okay.
So it's been staggered. So yeah, but if you're over 70, before 80, for whatever reason, there was a cutoff. Once you reach your 80th birthday, that was it. It was too late. So definitely try to get it done before then.
Super, thank you. And the pneumonia vaccine?
Pneumonia, so everyone is offered one stat dose over 65 years. So everyone should get that offer. Certain conditions may be offered earlier. So again, it's a one-off dose usually. It's usually not repeated unless you have certain conditions where they may ask for it to be done every 5 years. But again, you'd be invited for that. But once you reach 65, you should at least be offered one vaccine. So that may be something that you're offered. And there has been, it's pneumococcal, so it protects against a type of pneumonia. But it's not one you need every year like the flu jab.
Right, thank you. I'm now going to skip to the big question that you're not going to be able to answer, but I think it's important that someone's asked it. Will we all need to get a vaccine against bird flu?
Yes, I was looking up on that. So yeah, the answer is not known yet, but they're very much tracking it. And obviously we're worried about a potential next big pandemic. So people may remember, but there was a bit of a, what was it called? The one that we gave antivirals for about 10 years ago, as such, so it's
Was it
more
the swine
treatment.
flu?
Swine flu, thank
Yeah.
you. That's it. Yeah, swine flu. So whether we have to get into that, can you still hear me? Am I still there? Some people
Yes,
have
yes, you're
voices.
there.
Yeah, we're still there. So whether we get into that, but yes, they're tracking that very carefully. There isn't a vaccine there yet, but I'm sure they'll be looking to do several things at the same time, as well as we never want to get to a place where we're being locked down and locked away from each other and all those infection control measures. But everyone is on high alert for what that next pandemic may be. We see one roughly every 100 years. So hopefully it's not, it's further away than some of the fear mongering is saying, but it's important that we keep active. We're tracking because we're very much a global world, aren't we? So we're tracking what's going on. And I think a lot of the shared information that COVID brought about has helped with picking things up a lot earlier than maybe they would have done beforehand.
Yes. I distinctly remember swine flu because it was at its peak in high summer, and suddenly we were at winter workloads in the middle of summer, and I felt remarkably aggrieved about that. And then it all went away, and I think a lot of people relaxed. I certainly did. And so when COVID struck, I was thinking, oh no, not another pandemic. But of course, it was much, much more severe. And bird flu is potentially a very, very nasty one. People are talking.
And interestingly, last year they were locking all the birds away as opposed to locking all, especially domestic bird. You couldn't get an organic egg because they were and free range eggs because they were keeping them indoors to stop them maybe catching it from wild birds. So
Wow.
who knows? Who knows?
Right. I'm going to just go to a couple of things in the chat that are COVID related, so we keep them roughly in the same place. From Faye, how can you track infections currently accurately re-COVID, as there's no testing unless you're hospitalized? Now, I know that some people know they get COVID because they get classic symptoms like losing their sense of smell and things like that. But it's quite difficult, especially if you've had your jabs, to differentiate it from a nasty feverish cold or a mild flu. So what have you got to suggest about that?
Yeah, no, it's a good question. And yes, they're not tracking it the same way they did in the height of the pandemic when there was mass free testing. But absolutely, they're monitoring the hospital data because ultimately that's the one that causes harm, doesn't it, in terms of admissions and serious admissions to ITU. So they track those numbers and see those levels are very much under control in a way they weren't, at the peak of the pandemic. So it's a intentional kind of, because we don't measure flu, we don't test you for flu, for instance. So when something is endemic, the benefits of regular testing or individualized testing of the whole population outweigh, any potential benefits. So there's no need to, but they track the data for those more severely impacted. So it's always about the impact. So those who are in hospital, who are admitted to ITU, who are unwell with other things. They're tracking that carefully. And obviously there's also global data of those admissions as well. So that's what they're looking at. Whereas you're not going to get the numbers infected. We don't have those numbers like we had presented to us in the height of the pandemic, because it's endemic. So those numbers are less useful in an endemic situation compared to a pandemic situation. So hence that's why the shift and focus is on those hospitalized. And I don't know that they are they testing everyone in hospital each time? Maybe someone can tell me each time you go in? Maybe for infection control purposes?
I think they're only testing if you're you have a planned operation, perhaps.
Okay. Okay.
Not so sure at the moment if you end up in A&E, whether they're testing.
Routinely testing anyone, yeah.
Yeah,
We used to get a lot of the results back of routine tests, but we're not getting that. So I don't think they are just blanket testing everyone in the same way they were during the pandemic, because we have shifted to endemic situation now.
Yes, and the ONS, the Office for National Statistics, ran a screening program, which I was on. I was just one of those that was chosen, and ages ago now. And someone used to visit me at home and test me, and I would take a finger prick blood sample and send it off, and then it went online, and I did it at home and filled out an online form, and then they stopped it about 2 months ago. They said we've wound it up completely, so I'm not sure there's anything else going on at the moment.
The tetanus, did you see that tetanus question?
Yes, I was about to go to that. That was the very first question we had.
Interesting.
Now, this is possibly about a vaccine that you don't need to have, Peter. Whilst working in the garden this morning, it occurred to me, should a gardener have a regular tetanus jab, and how often? Now, that's a really interesting question, because classically, it was gardeners who caught tetanus because tetanus spores hang around in the soil. And I certainly had all my tetanus jabs. And when I had an injury, this was many years ago now, I was given tetanus boosters. But then I read that as long as you had your first initial childhood doses, 3 or 4 doses, you didn't need any more because it was such a good vaccine. Who's right in this one? And does Peter need a tetanus booster?
So I've just potentially joined on my laptop in case you may see the invite. So in case I go in a minute. But tetanus, yes, no, it's a good question, really good question. So at the moment, I think we're recommended if you've not had one for 10 years, you should get a booster. People come and get it when they're traveling as well. So they'll come in and check. And so we'll check. If you don't know, like when I used to work in A&E, if someone had an injury involving soil or outside or deep cuts, if they couldn't remember, we would just give them a top up, because it's better to be safe than sorry. So you can't be injured by having more doses sooner. It's always better to have extra cover than not be covered. But we don't see it. And this is what I mean about we need to change some of the terminology from vaccines to the disease and the issue we're protecting against. So tetanus, I've never seen it in my medical career, and I don't want to ever see it, because we have been successfully vaccinating against it for generations. So yes, I would say if you've not had one for 10 years, probably best to go and get a top up. A lot of people, it's usually diphtheria, tetanus, and polio. So it's a 3-in-1 vaccine given as that booster. So I'd say if you've not had one for 10 years, Mr. Peter White, check that and get your top up.
Right, there you are. Well, and I thought I was safe and secure. So a slightly side issue, and it goes back to vaccine fatigue. We don't see these dreadful diseases, and so we think we don't need the vaccine. I read just in the last week, there's been 2 or 3 babies died of whooping cough. I know this is way off the issue, but just appreciate, I was doing my GP training in the last whooping cough epidemic, which was over 40 years ago. It was in the early 80s. And I saw lots of babies and young children with whooping cough, and it's the most terrible disease. Now, I was working in a community hospital, and when they got that sick, we shift them off. We used to shift them off to the big hospital, which had an intensive care unit. But it was dreadful, and I was absolutely heartbroken to read that babies are dying of whooping cough still. And measles, likewise, is the most ghastly disease. Most people get over it. I got measles and I got over it, but there are quite a lot of children, particularly, who get brain complications and even die from it. Now, I mention that because it's just so easy to forget why we do these immunizations in the first place, and so easy to get too relaxed about it. So
that's it. And it's a question about, someone said my husband is really against vaccines. How do I try to convince? And we had a mum yesterday that didn't want to have her child vaccinated. And my job is not to convince. My job is to give you the information and then you can make a choice. But I always say we need to go away from vaccines has been turned into this weird words that's politicalized, or, there's big, either you're for them or against them. But actually, let's talk about the infectious diseases. Let's talk about whooping cough or pertussis. Let's talk about diphtheria. Let's talk about all of us. My generation of doctors haven't really seen measles, but we're having to look up what that rash looks like because they're outbreaks, and we're now seeing it in our clinical practice, whereas it's something we've not seen for the last 10, 15 years in such numbers. Let me look at what mumps looks like, rubella or German measles, Haemophilus, polio, which can cause, disfiguring disability and, all sorts of horrible complications. So let's remind ourselves of the names of these diseases and then remind ourselves what we're protecting against. Meningitis.
This meeting is being recorded.
My fault.
hello?
Can you hear me? Have I
Maybe we should all mute.
Yes.
Just leave
Can
the
you mute
speakers.
everyone? And if you've
I think
logged in on your
you're in
laptop as well.
twice. So will I keep you on your laptop or on your NHS one? Because you tried to get in twice.
Let me go on the laptop just in case, because I thought that froze. Can you hear me okay?
Yeah.
Yes.
Perfectly.
And you can see me. Yeah. Let me go on the laptop in case of what was happening. So what did I last say? Infectious diseases. I was on a thing. I think we need to go back to the diseases and remind ourselves we've had babies die of pertussis, completely preventable, because we're offering vaccination to pregnant women to protect those very newborn babies before they get their own jabs from 2 months of age onwards. So I think we do need, there's the 3 C's, confidence. You need confidence in the vaccine that's been offered. It needs to be convenient and accessible. So we have the NHS, so we're not charging people for these vaccines. So that's great. But we also need to deal with complacency, because we live in a place where we've had vaccination and we have the NHS and we have had good coverage. There is complacency because we don't see these infectious diseases anymore. And we don't think they cause harm. But actually, we need a conversation about the complications of these infections and diseases themselves, and the fact that complications or even death can happen. And that's why we want to prevent with vaccination. Vaccination is not just about preventing the infection. It may be that it's a very milder form of the infection that's obtained if the infection is still caught, because nothing is 100% protective. So I really agree about that complacency aspect. We probably need to deal with a little bit more as we widen the conversation about vaccinations and take it back to actually 6 in 1. What does that mean? Let's break down the 6 diseases we're preventing against in terms of childhood IMS. Shingles is later on, influenza. Every year, flu vaccine uptake as well can be a little bit rocky. So we need to remind ourselves of some of the complications of full-blown flu and what we're trying to prevent. Same with COVID. So yeah, I think that's some of it's a bit of a sideline, but it does answer one of the questions that was asked about how do I have conversations with people that aren't confident in the vaccine. And it's fair enough, absolutely fine to not have confidence, but let's have an honest conversation of what vaccination is trying to achieve.
Thank you very much indeed. And on that note, I think we're going to take a break. We've actually rattled through the questions. We're well ahead of time. But I think it's a 5-minute comfort break time for everybody. And
Now
see you
check if
guys.
someone's working in the IT cupboards and causing my IT issues. Apologies again for all that.
My clock says 12:01, so we'll reconvene at 12:06. Thanks, everybody.
Thank you.
Okay. I'm sure people will start to reconvene over the next couple of minutes. I am aware that we haven't answered every single question. If anyone's got a burning question that you've either asked already beforehand or in the chat and want us to go back to, please put it back in the chat. Because I don't want to anyone to feel that they've missed out. I think we've covered most of the questions. Oh, I didn't cover the one about statins. Actually, that's an interesting one. I was told I could take plant sterols instead of statins. Is this true?
Should I start? Go back? And...
Why don't you? Welcome back.
Hello. Hopefully, someone else is having issues. The others are having issues. So it looks like it's a issue in the practice. So apologies again, but hopefully it might be a bit better on my laptop. Plant sterols. So do we mean the Benecol drinks or supplements? But either way, the main evidence-based for lowering of cholesterol with medication, and not just lowering cholesterol, improving outcomes. So we use statins for two different reasons. Either primary prevention, so you're deemed to be high risk because we put things in a calculator and overall, or you may have a family history. So we want to prevent you from having that stroke or heart attack. So we may put you on a dose of usually a atorvastatin or simvastatin, low dose, and then look at your cholesterol level. And again, it's about monitoring outcomes. So have we reduced something called your non-HDL cholesterol by 40% by that intervention of the statin? So it's not just about taking statins. We need to be monitoring your bloods afterwards. We also put people on statins because we want to prevent secondary prevention. So you may have had a heart attack or stroke, and we want to prevent you having another one. So those are the two main reasons. So, and then there's some that have a genetic condition called familial hypercholesteremia or hyperlipidemia, and we want to reduce the cholesterol that way. So we may prescribe statins. So alternatives are lifestyle. We've already talked about eating the rainbow and keeping active, keeping well hydrated. Plant sterols have some evidence base behind it, but the evidence base won't be as strong as statins. So again, if whatever you want to do, always look at the outcomes. So I can't advise you on plant sterols because I've not been trained as much on it, but is it lowering your cholesterol level? So do your blood test before, have your baseline, take it for 3 months, repeat the blood test. Is that outcome where are your levels where, again, know your numbers and know what your goals are. So there's a buzzword called personalized care and personalized care planning at the moment. And if you have a chronic condition like hypertension or diabetes, or you've had previous heart disease, it's important to get an idea of what you're taking, why you're taking it, and what the outcome should be. Outcomes should be preventing other strokes and heart attacks. Outcomes may be getting your blood pressure to a certain level, because we know below that, risks of complications are lower. Outcomes may be getting your cholesterol below a certain level, because again, evidence shows us that prevents problems later on. So know your numbers, know what your outcomes are, but we need to measure them. So maybe that you're having that blood test every 6 months or once a year, but you have that personalized care and you have an awareness. I always call the GP consultation a meeting of two experts. So you're the expert in your everyday life, your lifestyle, what your habits, what works for you, what doesn't. I'm the medical expert. And together, we should be able to come up with a shared decision and a care plan that will work for you, and also a clear awareness of what your goals are, so, and what the medical goals should be, as well as your personal goals. So I really think that personalized care planning should be, we need the time and the staff, and it may not be with your doctor, maybe your practice nurse or an advanced nurse practitioner or a pharmacist, or we have nurse associates. So there are other members of the team that may have this discussion, setting out these clear goals. So plant sterols, I can't say yes or no, like any supplement, what are you trying to achieve? And if the outcome is, I want my cholesterol to reduce by 40%, then measure it. And if it's working a lot, and it always has to be a long start to all those other lifestyle things we've already talked about. If it's working, fantastic. If it's not, let's think again. So always bear in mind what we're trying to achieve. It's not just reducing cholesterol. There's usually a specific number that we all need to be better at monitoring, I would suggest.
Thank you. Thank you for that very comprehensive answer. Now, Aaron, I haven't forgotten you a second time, I promise, but I'm just going to go to Simon's question because it's on the same general issue. Does anyone produce a list of most foods in order of healthy eating, i.e. from unlimited eating to don't ever touch? And I sense there's a doctor's wagging finger waiting to come out here and say, no, you mustn't, and yes, you must.
Like the unlimited one, unlimited.
Well, that's a really interesting question. Like, ultimately, as I'm talking to you, I'm talking to myself in terms of the eating the rainbow, keeping hydrated, moving. So these are things that aren't always easy. Some people do it better than others. I was so saddened to hear about Dr. Mosley, who has done some most remarkable work in this area, remarkable work. So if any of you have a chance to look at some of his books, he has some really, or watch his TV programs, because others get information better that way. I think he has some really great, practical, achievable ways to get things done. So I don't think there's ever a never list. We always talk about processed. I mean, I think information about ultra processed food is becoming more well known. I always say we all need to be in our farms, growing our own greens and rearing our own cattle, but we're not. We live in urban cities and we are reliant on the mass production. So I do think the food industry, there's a lot of work that can be done in terms of helping us with ultra processed food, the sugar and salt and fat content in our food. Whole foods is always a good idea. So things that come out the way it comes out the ground and cooking fresh from that way. And I think you always have to I just came, when I got logged off last time, came back to Dr. Tony talking about what do you enjoy? You know, it's not sustainable if you're not enjoying it. So you need to incorporate food and things and tastes and flavors that you like in whatever plan you're doing. So I think a rule of thumb is if it's ultra processed, really try to limit it, you know, reduce it right down. Even all the worry about bacon and processed meat and bowel cancer and things, it's not a never, ever, ever. If you really enjoy it, then have it as that treat. But it shouldn't be something you're having every day, you know? So that's, again, everything is about balance and making sure you're doing things that you enjoy, but balancing it with eating that rainbow, making sure you're getting your protein and your vegetables and your fiber in, because I think fiber, we have a real fiber deficit with when we go for processed stuff. You need the roughage, our guts need that. So everything's about balance, but make those small steps that you can maintain, because there's no point doing something that you're not going to be able to maintain. And then bit by bit, you can add to it. But there's some great resources out there online, NHS websites, there's a Better Health website, there's apps to get us moving a little bit, even though, disclaimer, I've had Couch to 5K downloaded on my phone for many years. So, but this is the year that I will try to do it, you know? So they're little things to just get you doing things slowly with food, with movement. And in particular, Age UK have some great resources. Like we talk about muscle is strength, you know, building strength and exercises to build that muscle, because that's what's going to really help with reserve as we all get older.
Thank you. I wouldn't disagree with any of that at all. But in the immortal words of, was it the very first TV chef? Here's one I prepared earlier. There's a link I've put in the chat from Age UK on specifically on healthy eating, but I think you can get to the other well-being links through that part of their website. And yes, make it enjoyable and make it sustainable. Now I've got a bit more time on my hands, I'm really surprising myself at how much I enjoy preparing my own food.
Okay.
And I have a freezer and I can batch cook it, batch freeze and all the rest of it. And it makes life really rather more interesting than I was expecting when it comes to eating. So, you know, that's great. And getting out and about, not being stuck in front of the wretched computer all day or listening to the music and reading a book, just making sure you get your exercise and stuff. So all good. Now, I do want to go back to Aaron because Aaron asked a question originally and I skipped it. Aaron, I asked about my kidney infection. My left leg gets swelling up. Is there medicine for it? Now, the original one was, my legs are swelling up. Is this a kidney problem or could it be something else? It sounds as if you've had a kidney infection, Aaron, and now you've got leg swelling and you want to know what to do about it.
Yeah.
I'm
I go
assuming.
on? Yeah.
So that was the question.
That was the question. So leg swelling, it's a really common problem and it's something that we do need looking into. So it's a common presentation that people come, especially this time of year where the weather's getting a bit warmer. So my ankles are swollen, my feet, my shoes don't fit properly. What's going on? I've noticed when I get off a flight now, I get lots of swelling. And there are different reasons for it. Some of the most common ones are, you may notice that when you go to bed and you're lying down flat, the ankles go down overnight and it's a gravity effect. So as you stand up and you're out and about or sitting with your legs down, there's a dependent swelling, which is a gravity effect. And it's just because the vessels aren't as good at pumping blood and stuff back towards your heart. So keeping your legs elevated or some light compression may help. But there are other more serious causes of leg swelling that's important to exclude. So if you have swelling on one side compared to the others, worst case scenario would want to rule out is maybe a clot in the calf, a DVT. So would want to be doing checks to rule that out. If both sides are swollen and it's not really going down, or you may have other symptoms like breathlessness, would want to rule out an issue with your heart. And there are tests we can do about that. Linked to kidneys, if you're not weeing properly, we may want to do some more tests around the kidneys if you keep getting infections or your kidneys aren't working properly. And that can also be linked to blood pressure and other issues. So just leg swelling, it's easy to put it down to a bit of swelling in the warm weather, but it is important that other things we can rule out. And that's where a GP appointment should be able to look at this thing, look at you as a whole. They'll know your previous history. You can talk about what symptoms you're having that you may not think are linked to the leg swelling, but we may be able to put together, and then you come up with a plan to investigate it a bit further. So in a lot of cases, it may not be anything to worry about, but it is important to get that checked out. And if there's medicine for it, it depends on the cause. So you have to treat what the cause is. If it's an issue with the heart, we have to deal with that. If it's an issue with the kidneys, that has to be dealt with. If it's simple, just swelling linked to warm weather or to gravity, then elevation and compression stockings can help. It's not always easy to wear stockings in this weather. So elevation and inadvertently keeping well hydrated. So making sure you're drinking plenty of water because it makes sure the body keeps the fluids in the right bits of the system, if you like. So that's something I remember reading recently and thinking, actually, that's a good tip. So, but it depends on the cause in terms of medication, because the common one that may be given are water tablets, but it's important not to give them just like that because they have side effects and they can put pressure on your kidneys and can cause lots of other problems. So it's an important thing to have a careful conversation with your doctor about finding the initial cause and then trying to find ways to reduce the occurrence of it or manage it. Hope that answers the question.
Thank you. So there's all sorts of causes for leg swelling, some straightforward and not too much of a problem, but it can indicate something more serious. So if in doubt, ask your GP.
Get it assessed properly. Yes, exactly.
Yes. I'm on blood pressure medication, amlodipine, that makes my ankles swell, not too badly, but at night time, all the fluid comes out and guess what? I'm getting up in the small hours to go to the loo all the time now. Fortunately, I get back to sleep, usually. Now, that brings me on to a question that I skipped before. What is the correct amount of water to drink in a day, or does it depend on my size and weight? Now, you've mentioned, hello, can you hear me? Yes. You've mentioned coming up to the warm weather, and this is a particular issue in the warm weather. And again, thinking about poor Michael Mosley. So how much water should I drink?
So it's a really good question, and there's no straightforward answer. If you talk to my mother, who was a GP for a doctor for over 50 years and sadly passed away last year, but I do everything in her steps. She was a big water drinker and a big proponent. So she was always like, have you drank water? You're not drinking enough water. So that was her cure for everything, drink water. But it is important to balance it. If you have heart disease or severe kidney disease, end stage, you may be restricted with the amount of fluids you can take each day. So you would be told that by your specialist or your doctor. So you'll be aware. Also, what are you drinking? So people say, I have 6 cups of tea a day. This was a patient just last week, 6 cups of tea a day. You know, tea is lovely, but it has caffeine, which is ultimately a diuretic. So will make you pee and dehydrates you. So it's not hydrating. Water is hydrating. You know, sometimes you may want to add a bit of squash. Some people squeeze lemon or fresh fruits, which is great, mint leaves. There are different ways to flavor water to make it more palatable if you don't like plain water. But ultimately, you want to keep hydrated with water. Rough rule of thumb, it can depend on your weight, but a liter and a half is probably good going. In hands up, I don't manage that most days. But judge it by the color of your pee is the other way. So we have a chart in our staff loos here that shows the different color from Coca-Cola all the way down to a light yellow. So it will say if you're drinking enough by the color of your pee. So that's a really simple way to maybe judge if you're hydrated. In hot weather, you're sweating more, your cells are working harder inside, so you may need more than in colder weather as well. Some people like to drink earlier in the day because they don't want to be up all night, or maybe you can't prevent getting up at night, as Dr. Tony just said. So again, judge it by, you should be drinking, rather than have that big bottle that you then take all at once. Ideally, it's better to drink a bit each hour, especially if you have a heart condition or a kidney issue, consistently, little and often throughout the day, rather than great amounts in one sitting. But if you're doing exercise or if you are in hot weather, it is important to drink more because you're sweating out more. So let the color of your pee be potentially a guide.
And I'm just going to add a little something, because one of Age UK London's other campaigns is the London Lose campaign, out and about. And the difficulty of finding a loo when you're out.
Yes.
And this is particularly hard, it's not just older people, but particularly on older people. And I know that a lot of people go dry before going out, or even avoid going out at all in the first place.
Yeah.
You've got to be really careful about that, particularly in the warmer weather, because it gets terribly easy to dehydrate, and older people dehydrate more easily than younger people because our thirst mechanism that makes us want to drink isn't so acute. And so you have to be really, really careful about that. And it's not easy, but that's why Age UK London, quick push here, is running this London Lose campaign just for this very reason.
Very important. I think I gave myself a kidney stone in school because I didn't like using the school loos, my mum would tell me, you know? So it's a real issue, you know, because you want to avoid. So it's a real thing. So you need to, hydration is so crucial, but good toilets and access to toilets is essential.
So someone's asked, Mary Jo, does low blood pressure matter? And I think the answer is it can do, but
yes.
Can you elaborate?
So yeah, it can do. Again, you should know your numbers. Know what is normal for you, because someone else's normal might be someone else's that's way too high, and vice versa. So low blood pressure, your blood pressure may drop as you go from sitting to standing. And this is particularly more common as we get older. And also some blood pressure medications can increase the risk of this. So it is important to sometimes check your blood pressure from a sitting or lying position, and then stand up and check it, because that's another measure of if your medication is working for you as it should without some serious side effects. If your blood pressure is dropping too low, then is it over medication? Is there an illness? It's one of the signs of a severe infection, so it can matter. Is it causing you symptoms? So are you feeling dizzy when you stand up? Are you, having the world spin? Are you unsteady on your feet? Because falls is a really major issue. in the older age population, and dizziness or side effects from medication or low blood pressure dropping suddenly can be one of the causes of that. So it does matter. But if I just had someone, we have a pod in our waiting room, and one of the receptionists said, oh, this blood pressure is 98, the upper number, over 70. Does that matter? And this was a young, 25-year-old that, was just getting a pill check. So that was normal for her. But if this was a 80-year-old man whose blood pressure is normally 150 over 80, it would not be normal. So it's always about that personalized care. What is normal for you? What have you had before? And also what symptoms does it cause? And one of the things, talking about hydration, keeping well hydrated if you're prone to low blood pressure is a way to try to control and manage that, one of the ways. But it is important to make sure there are not other causes that are making that more of a serious issue.
Thank you. Yeah.
Thank you. Now, I'm going to come back to a couple of questions, but someone, D, has just put in the chat, I put a spoon of electrolyte in my first glass of water of the day, and this stops so many trips to the loo when drinking water throughout the day. It seems to work.
Okay. Electrolyte as in a mixture of salt, or?
I assume so.
Electrolyte, is it a sachet you get? It'd be interesting to know what that's made up of. But yeah, some people talk about a pinch of salt or potassium.
Yeah, she says yes, it's a sachet.
So it must be made up of certain things. So potentially sodium, which is like salt, but you don't want to overdo it, and other things. Interesting. That's a good tip then. Worth trying.
Right. Now, to go back to the previous two, can osteoarthritis cause swollen knee areas?
Yes, absolutely. So osteoarthritis is wear and tear, where the joints can narrow, and like worst case scenario, you may get bone on bone, but the joints and the cartilage and the tendons can just wear. You can get bony spurs, and it can be very painful. And commonly, the most common joints are your knee or your hip, but you can get osteoarthritis in your shoulder, in your back, in any joints effectively in the body. So it can cause swelling and pain and difficulty moving. And you can manage it with physiotherapy and pain relief, but the definitive treatment, if it's bad enough and affecting your day-to-day life, is a joint replacement. So we commonly see knee and hip replacements done. So it's a conversation if it's really affecting things, but absolutely it can cause a swollen knee, one of the main causes of it.
Thank you. Now, a change of tack. Maria, could you elaborate on the recent discovery about inflammatory bowel disease, please?
I think it's a genetic discovery, which is exciting news, but yeah, I'd be happy to hear the elaborate. Oh, I want to elaborate, or Maria's going to elaborate?
You're elaborating.
I'm elaborating. I probably know, it's not my area of expertise, but there's some I've just seen in the Crohn's and Colitis UK, groundbreaking piece of research. So they may have found a major new cause, which is one of the genetic codes. So they're hoping that they will then, once you find a cause, you can potentially find a medication or treatment that attacks the cause. So it seems very exciting because it can be very debilitating for many in terms of bowel, and can increase your risk of cancer, bowel cancer, and other issues, and also side effects from the medication that's used to treat it. So the really great thing about this discovery is they've discovered one of the major genes they think that's causing the issue. So that's potentially a treatment target in future. So exciting times. That's why research is so important, and getting involved in research and getting involved in trials and having the right funding for research is so crucial. So a lot of these organizations, Crohn's Colitis UK, Cancer Research, they do such great work in those spaces.
And research sometimes takes years and years and years, and people fever away, and then suddenly there's a breakthrough, and sometimes it's, what's that quote about inspiration and perspiration? Genius is 99% perspiration and 1% inspiration, but one day somebody has a great idea and then everything starts to fit into place.
Yeah.
And you never quite know. So I think I think research is exciting, although I was hopeless at it when I tried.
Yes, I didn't have the patience, but there's more scope to get primary care and GP surgeries involved because we have patient lists and get more primary care patients who maybe don't have hospital input have these trials available to them as well. So, and there's exciting new development in dementia as well. That was in the news a few months ago in terms of treatment for dementia, which is an area we've not seen real, treatment options in for a long time. So, research is crucial for things like that.
Right. Any guidance on restless legs?
No, the restless legs affect people in different ways. I am a big fan of quinine. I think it works really well. That's the key thing after just ruling out any other causes. So electrolyte disturbances, calcium imbalance, any other causes of it, trauma. Quinine at night, so either a tablet or some tonic water, has done wonders in a lot of my patients in helping that. So that's just a quick tip. But you want to make sure there's no other major causes, but sometimes it's one of these things that we don't know why, and it affects some people more than others. But tonic water before bed can really help. Yeah.
Okay. Oh, and Sharon Tynan wants to know how regularly the NHS offers general health checks over the age of 65.
That's a good question. A patient asked that the other day, actually. And so, so it's a really good one. So there isn't any, there used to be like, what do they used to call it? Was it 70? Maybe Dr. Tony, you may know. Did they used to contract checks for the older age group?
Yeah. Oh, there was originally over 75. Yes.
Yeah. So at the moment, at 40, you can get an NHS health check. And the point of that is to screen for cardiovascular illness. So it checks your cholesterol, your kidney function, your diabetes screen, your blood pressure, your weight, and takes a lifestyle advice and gives you a risk score and gives you some of the goals we talked about in terms of outcomes and looking for conditions, but also prevention of conditions. So there are no set checks over the age of 65, but we do know by the time you reach 65 or you're over the age of 65, you may have one or more long-term condition. So there should be annual reviews or more than 6 monthly or whatever the condition is, reviews attached to that. So most common ones, diabetes, heart disease, heart failure, asthma, COPD, etc. If you're on medication, you should be having an annual review of that medication. It could be a paper review. There may be blood tests associated with it, but you should be on a general basis having an annual review. I would suggest anyone over the age of 40 even get their blood pressure checked at least once a year, have an idea of their numbers. So once you've done that NHS health check, if the numbers are normal, you may not be offered another blood test for 5 years. But I think, again, in that personalized care, if you know you have a family history of diabetes or heart disease, if you know you've made changes and you want to know if it's affected your cholesterol, you should be checking that and having that conversation with your healthcare professionals to get that checked. So there are no specific checks as soon as you hit 65. The only thing you'll be offered newly, if you haven't had a condition that offered it to you before, you'll be offered the flu jab and the pneumonia jab. So flu jab every autumn, and the pneumonia jab is a one-off. So if you've not had that before, you'd be offered that from 65 onwards, and potentially the COVID jab in the autumn season as well, if we're following what we've done in previous campaigns. But there are no specific checks, and may be linked to a long-term condition you may have. If you're lucky enough not to have a long-term condition and not to be on any medication, I would advise keeping an eye on your blood pressure and knowing what your cholesterol levels are as a baseline.
Thank you. And one for the gentleman. How regularly should men get tested for prostate cancer?
Great question. I just gave a whole talk on this recently because it is an area that I think awareness is getting there. So prostate cancer, I gave a talk on cancer screening and then discussed prostate cancer because there is no screening test yet available for prostate cancer. So at the moment, we get sent bowel cancer kits from 60 onwards. Women are invited for smear tests from 25. And breast cancer screening from 50, even though that's going to be reduced soon. But there's no test for prostate cancer. at the moment. There's a screening test for abdominal aneurysm from 65. So men, is it men and women? I believe it's men and women. It used to just be men, but it's now men and women invited for that. So, but there's no screening for prostate cancer. We know that there is a blood test called a PSA, but it is not a good screening test. Otherwise, we would be offering it. But in the gap of not having a screening test, the NHS has actually said if you're above, it's the age 50, you need to double check this, and 50, but 45 if you have a family history or you're from a Black background, because we know it starts earlier and is more aggressive. So from 45 in those groups, it says, but from 50, you can ask, there's a specific term for it where you ask your GP, I would like to have this test. And then we should have a conversation with you about how it's not a right screening test. We should be asking you if you're having symptoms of lower urinary symptoms. So things like, already mentioned, waking up maybe 2, 3, 4 times at night to wee. Maybe you feel like you're not emptying your bladder properly. Maybe you have the flow is not as strong as it gets there. And the reason why the blood test is not a perfect screening test is if it's raised, it could be down to a whole bunch of different things, of which prostate cancer is only one of those things. And we know the prostate enlarges with age as well. So that causes a raised PSA, which is that blood test level, as well as infection, exercise, lots of things can cause a raised PSA. So it's important to have that conversation and about symptoms, if you're having any, and also if you, what the level may mean. Above a certain a level, and it's age specific, you may be referred for further tests. And those further tests can be invasive. They're getting better. There's an MRI scan that can identify hot spots. And if they see a hot spot, then you may be offered a biopsy, which is to look at it under a microscope in a bit more detail, looking for abnormal or cancerous cells. So the biopsy is not without risk, which is why you don't want to be biopsying normal prostates, and there's like a risk assessment. But the MRI scans are getting much better, and there's lots of research into getting a better screening program. But in the gap of that, if you're worried, you know you have a friend or a family member, more importantly, or you're from that Black background, you can ask for that test. And I actually advise Black men to get it as maybe part of their health checks if they haven't had their NHS health check. But you have to have that conversation about what the result may mean and what it may mean in terms of further quite invasive investigations further down the line. But it's a good opportunity to have a chat about actually what do you understand about your bladder, your waterworks, and how that may be changing as you get older, and is anything happening abnormally, and then come in and getting advice for that and not relying on just the blood test too.
Wow, well, that was a pretty comprehensive answer.
But I didn't actually answer the question, how regularly. So if you know your number, it's also about seeing what trends that changes. So it's a difficult one because there is no set program. But if you're having a cholesterol test or blood test because you're on blood pressure tablets, there's no harm keeping an eye on the numbers, maybe annually or every 2 years. If there's a known issue with your prostate, then you may have a plan to check it every 6 months or every year. That's usually directed by the specialist. So again, it depends on that personalized care. But as a rough rule of thumb, I would say that.
And it's interesting because some countries do have a regular screening program using PSA, but it's a real hot potato.
Yes.
As you said about false positives and stuff like that. And so it's not an answer like cervical screening or other screenings. So it's a really tricky one. And to make it worse, you can get prostate symptoms. Well, fortunately, you can get prostate symptoms without having cancer because lots of older men have prostate symptoms, but you can also get prostate cancer without having prostate symptoms.
Yeah, exactly.
So
and with a normal PSA. So there's a small percentage that PSA could be normal, but you may still have prostate cancer. So it's a very complicated area. It's not straightforward. Yeah. But I always say people should know, like I said, you're an expert in your body. You know what's normal for you. You're with your body every day. So any changes that you just don't quite understand, it's important to have those conversations and let's have a talk about symptoms, you know, rather than focusing on specific tests. They can be a guide, but we always put them in the context of that person in front of us and
Yes.
what symptoms they may be experiencing.
Yes, thank you. Are there any questions that I have missed out that people really want answered? Or have you got any new questions? We've got potentially another 20 minutes, though we were so ahead of ourselves earlier on, we could always wrap up a little bit early. If there are any burning questions, can you put them in the chat right away? Otherwise, Sharon has got a few things to say, and there's the inevitable evaluation inequalities form. Any last minute ones? Asmina has asked about screening for lung cancer.
Screening for lung cancer.
Before you go there, Dr. Ilozue, I was just thinking, just in case any of the attendees aren't, you know, you're not familiar with being able to use the chat, if you want to put your camera on and or say hello, or and we can unmute you if you need to ask the question potentially, just in case they're not able to use the chat. Thank you.
I think Dr. Ilozue is looking for a link to put in the chat.
Exactly. Lung cancer. So there was a really great study that we were involved in as a practice, a lot of practices in North Central London or across, I'm sure it was national study, called Summit UK. So that was screening, had like low intensity, I think it was a low volume CT scan, because we worry about CT scan and the radiation risk. But I think it's quite a low radiation risk, or lower than a standard one. And it was screening a high risk population. So I think previous smokers was one of the categories for any lung nodules or anything that may be suggestive of early lung cancer. So again, any screening program has to have benefits. They always weigh up risk benefits. It has to be applicable to a large population. So you screen the whole population. You always screen in a healthy population. So you shouldn't have symptoms necessarily. And the idea of screening is to pick up before it even becomes cancer, in the example of cervical screening, and also early changes. So we all know early cancer can be treated much more effectively than later stage presentation. So we're keen. So that's the point of screening. So this CT scan in this population and picked up lung nodules or early potential cancer. And I think the evaluation is ongoing because they've stopped doing the study, but we'll hear more about whether or not it's going to be recommended to be a formalized screening program. So no official screening yet, but one of the things we were highlighting in the NHS, if you have a persistent cough of more than 3 weeks. Now, we've had a few winters where coughs have gone on for 6-8 weeks. But if you are coughing persistently for more than 3 weeks, the argument is you should be seeing your GP to at least get a chest X-ray as a first step, as well as take a history about other symptoms that may be worrying, and then investigate further. So you shouldn't be ignoring persistent coughs. You should be making sure that we have been assessing and investigating those.
Right, thank you. Now we've got 3 more questions. Gosh, some of them are quite tricky ones, actually. First of all, Sarah, any thoughts on air filtering in clinics and hospitals, particularly if there's an air conditioning system there already, I would add?
Yeah, I mean, they will have some quite strict checks in terms of checking for Legionella, having checks to make sure that they're properly maintained. There were lots of talks about ventilation units, especially with COVID, and there are specialized ventilated rooms if you're isolating someone. So I worked in South Africa for a year, and we had multi-resistant TB, and it was an isolated ward or room. I know in the UK, there will be special infectious disease units with special ventilation to protect the public from those conditions. So those are kind of my thoughts. I don't know much more about it than that. Don't know if the person that asked the question has any context, but they do try to filter the air. especially if there's an AC unit or filtration unit, to try to reduce. The aim will always be trying to reduce infectious risk.
Yes. Okay, now Aaron, who asked about his swollen legs, says, why do I feel dizzy most of the time when going for a walk?
So dizziness is one of those conditions that common presentation, but can have multiple reasons for it. And the first thing I'll do if someone says they're dizzy when standing or walking is to do that blood pressure, lying down, and then again, standing up to see if there's a drop, because that could be a cause. But there's lots of different causes for it. I'd want to be knowing that your iron levels are normal and want to know that, all your different organs were working as they should. So there's a whole plethora of tests we could do to investigate it, depending on your symptoms, how repeatedly it happens, if it's every time you stand up or just when you're exercising and walking. So there are other things I'll be thinking about. So dizziness is one of those symptoms that does need an assessment and an appointment with your GP or healthcare professional to investigate that further, sorry.
Yeah, that's super. Thanks. That's a really clear answer. Oh, and Aaron, you've put your thumb in the air. That's fantastic. Thank you. D, what can cause tiredness in an older person? Here's an easy one for you. My father-in-law in his 80s with low mobility, and what can he do to feel less tired all the time?
When you say easy, what do you mean?
I was having you on.
I was thinking, I was like, oh, because again, tired all the time, a really common symptom in any age group. And we can't just put it down to age. I really don't believe in that. Oh, you're just getting older, you should expect it. No,
Yes.
We should absolutely be assessing it fully again. So again, multiple reasons for it, but it needs a proper history, examination, investigations, and then management of what causes we may have identified. But again, it needs a full person assessment in terms of why. We can't just put it down to he's 80. There's 80-year-olds doing marathons and climbing Everest. So it is really important to have low mobility may be the one, and it's this vicious cycle. The less you do, the less you can do. But we need to have a comprehensive assessment of the reason, and that includes that history, that discussion of what's going on, maybe some tests, investigations, and then a conversation about managing it and making sure we're ruling out concerning causes of tiredness.
Thank you. Yes, there's 1,001 causes for it, isn't there, basically? Yeah. Okay, I think we should draw this part of the meeting to a close because I want to thank our speaker for being brilliant at introducing the subject and then fielding all these questions. Thank you so much, and you've done it in such a straightforward and easy to understand, accessible way, and I am hugely impressed.
Thank you. So sorry for my IT issues, but we got there in the end. So thank you for all the wonderful questions. There were some very insightful, interesting questions there. So thank you for getting my brain thinking this afternoon.
And we'll want you back, of course. I want to hand over to Sharon now, who's got some things to say, and then I'll close the meeting promptly at 1 o'clock. Thank you again, Dr. Ilozue.
Thank you. Thank you for having me. Always a delight.
Sharon.
I'm unmuting. Yes, just very quickly to say to everybody, I'll be forwarding an evaluation form just so that we can feed back to NHS London about getting the message out, etc., and whether you found it useful, and I'm sure you did. I mean, you've covered so many topics. This has been fantastic. Thank you so much, and for offering up your time today. So as I say, I'll be sending out an evaluation form, an equalities form, and I might also send some links. Bear in mind that pretty much all London boroughs are covered by a local Age UK. We're the London regional office, so we don't deliver direct services like that. But if you might, it could be Age UK Barnet or Age UK Lambeth or Age UK Ealing, wherever you are. They'll have exercise classes. They'll have, and if you feel you're not that mobile, they do exercise classes in a chair. There's also like strengthening and balancing. I believe Tai Chi is supposed to be really, really good for your strengthening and balancing. And an awful lot of Age UK's run Tai Chi sessions, nice and easy. And it's also quite sociable. You never know, you might meet some new friends as well. So again, for me, thank you so much for coming along, and I'll follow up with an email. If there's anything and you've got any other issues or queries, please you can reply to me again. I'm the person who sent the email out to you in the first place. And thanks very much. And I'll just pass over to Tony for a final catch up, I suppose.
Yes. Just to underline the importance of the evaluation forms, we do take them very seriously. We pore over them and ask ourselves, are we reaching enough of the right people? I know we've been talking about vaccine fatigue. Frankly, I frequently suffer from evaluation fatigue, and the equalities form. Now that's important too, though I will admit that sometimes I get creative when it comes to what religion I practice, because I'm answering the same questions again and again. But it is important, and we do take notice of the forms. And of course, NHS London will want to know that we were providing value for money, but we need to know that we're providing value for money as well. So thank you in advance for going to the trouble on that. Thank you again to our wonderful speaker, Dr. Ilozue, who's like a good GP, knows so much about so many different things, and more importantly, can put it into plain English and communicate clearly. And I really do appreciate that from you this morning. And thank you to everybody for turning up, for asking your questions, and for being a good audience. I meant to be summing up what we can all do to keep each other safe and healthy. I think the message is eat well, exercise well, and keep talking to people. And when in doubt, you know, the health service is there for you, and particularly if you're getting worrisome symptoms and so forth, you do need to ask. And sometimes you're going to the doctor and you say, do I need to be a patient? Because sometimes you don't, but sometimes you do, and there's only one way to find out. So thanks again to everybody, and thanks to Sharon, who does a lot of work behind the scenes in getting these meetings together. I just like swanning in and taking the limelight. And thank you again to our speaker, and thank you to all of the people who've attended to make this a very worthwhile morning session. Thanks again. And can Dr. Ilozue and Sharon stay behind briefly for a 2-minute debrief? But thank you and farewell to you all.
Thank you. It was absolutely brilliant.